بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. الصلاة والسلام على حبيبنا ومعلمنا وقدوتنا محمد صلى الله عليه وسلم. اليوم هنكمل الراوند بتاعنا في الهيمودياليسيس يونت عشان نقفل الموضوع ده، وإن شاء الله نركز على موضوع تاني أهم. لكن الموضوع اليوم أنت دلوقتي بتعمل راوند في الهيمودياليسيس يونت أيا كان السنتر اللي أنت فيه. هنكمله الراوند دلوقتي. Today just will concentrate now or this presentation just on the vascular access problem. Any problems either in AV fistula or central venous catheter. ده إن شاء الله بنحاول نغطي كل المشاكل اللي ممكن تقابلها في الوحدة بتاعة الغسيل وإزاي تتعامل معاها، وإن شاء الله تستفيدوا ونستفيد كلنا مع بعض ونراجع مع بعض. توكلنا على الله. بسم الله الرحمن الرحيم. ولا تنسوا دائما الآية المحببة لي، قال سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. صدق الله العظيم. بسم الله الرحمن الرحيم. وقل اعملوا فسيرى الله عملكم ورسوله والمؤمنون. صدق الله العظيم. بسم الله الرحمن الرحيم. توكلنا على الله. احنا دايما عندنا السنترال فينز، بس نبدا بالرسمه دي كتوضيح. انت فين الرايت انترنال جاجولار ده the best site and to insert for any patient recent dialysis or fresh dialysis or whatever. This is the best preferred site for insertion of temporary or tunnel catheter with the right internal jugular vein, and this followed by second one, this left internal jugular vein, and this subclavian is rare to be used or not preferred to use in a hemodialysis patient because this will be easy to be stenosed after that and central venous stenosis, and we'll see what is the problem of this subclavian vein. And either femoral right or left, this is if you have patient critical with pulmonary edema and respiratory arrest, and the safest place this place, but the problem only in this femoral area. Just DVT and infection is more common than this area, and we'll discuss all this in details. There are three types of basic types of vasculars. When I am doing round in my hemodialysis unit or center, just you just put in your mind, you should see, or you I don't know if it's available in your center, just you can see these three types of fistula. Just the AV fistula is native or natural fistula from just connection of artery to veins, or AV graft. This graft already put it with the patient have this poor veins, small veins. Just we can put this graft, synthetic material, and easy to palpable and sterile already. And CVC, central venous catheter, this is a common already tunnel catheter, either right or left or femoral, according to vascular access problem in your patient. AV fistula is just done by surgery, direct connection between arteries and the veins. AV graft, interposed, this is just عبارة عن وصلة between the artery and the veins, okay? On exam, what is important? Just put in your mind when you are doing round in hemodialysis, just look for a AV fistula or ask a nurse or checking notes of your nurse during your round. Good AV fistula examination, just this will detect early complication of your fistula or your patient fistula, and this will save your fistula if any problem in your fistula, either as we'll see in next cases, and saving a patient life. This AV fistula means patient life. AV fistula equal patient life, equal hemodialysis patient life. This AV fistula, life of hemodialysis patient. I think Keduke recommended just access patency should be ensured before each treatment, before any attempt to cannulate the access. This already should be done by nurse. Because the nurse is good trained for that. She should examine, and any abnormal issues, whatever we'll see, because we have different issues we'll see now in hemodialysis access or AV fistula. Please just inform your doctor to take action or take decision, or talk with your vascular coordinator to arrange for vascular to see this patient. All caregiver, including the fellows in training, should learn and masters the method of, for example, AV fistula or vascular access. All, especially fellows, you should all caregivers, consultant till resident, you should know. You should at least check nurse notes. You can look for access, and in abnormal issue for access, as we'll see in the next cases, you should refer patient to the best direction or the best subspecialty to deal with access to save the patient life. Okay. Monitoring and surveillance. Any patient came to with new fresh AV fistula, this at least just identifies a primary failure. You know what it means primary failure already. This is after surgery, before needling, whatever time post-surgery. After that, the primary failure disease not used for dialysis. This is a fresh fistula with no thrill, already died fistula. Plan for early intervention. This should be also monitored and assessed by vascular and by ultrasound, and we'll see the criteria. Plan for surgical revision or new access. This should be for new fistula. Just you need to assess the new fistula until maturation after 6 weeks or 2 or 8 weeks, and we'll see different cases now. Establish a fistula. If you have a fistula already used, early detection of the problem to prevent thrombosis, inadequate dialysis treatment. Early detection of the problem if you have venous pressure, bleeding after dialysis, whatever, just early detection to check any thrombosis or inadequate dialysis treatment from accessory veins, as we'll see in the next slides. Basic concept for any AV fistula or dialysis access. AV fistula is a continuous circuit start at the heart and end at the heart. It's not just anastomosis, as we'll see. This is not only the anastomosis here, fistula, not only this. There's already a continuous. You should hear or palpate or listen all this area until the heart. If you will examine, you should examine all this arm. If you will hear or listen or auscultate, you should auscultate from the anastomosis till the heart. Okay, this is a blood pumped to the fistula and the blood again from the fistula to the heart. This is a continuous circuit already. Yeah. How to examine, as we all know and or read before in the box, how to examine the AV fistula. Just look, feel, and listen. Look as an inspection, just as the first thing. Just look for the fistula. When a nurse starts to dialysis, she should look any signs of friction inside the hematoma or bleeding or bending rupture aneurysm. Should all this be seen by looking during her before her starting cannulation to her patient in the hemodialysis unit. Just to feel or palpate. You should palpate your fistula. Nurse should palpate that to be sure this really is okay, with no abnormal finding and nothing warning to the fistula for her patient. And listen, auscultate. You should auscultate your fistula. If you have cystoscope, you should any fistula should be auscultated for any abnormal murmurs or any abnormal sounds, and to be sure your fistula is still alive. And this should be done by nurse, by attending physician with her, by head nurse, whatever is available in your unit according to the protocol. But the best thing to be done by nurse, if any abnormal finding should she should call her, attending physician with her to see or solve the problem of the patient. And we know this direction of the inflow and this outflow. This is our AV fistula, radiocephalic AV fistula, and this inflow, the feeding artery to the fistula. This is a radial artery, and this already cephalic veins. That's just this the venous side. The blood go to the heart already after dialysis, and this feeding artery is a radial artery, just giving this blood to the fistula. And after that, we'll return back to the venous side. This is arterial side to the fistula and venous side to the heart after dialysis. As this we know, this is a feeding artery. Feeding artery this is a radial artery, and this already this venous this is already venous return to the heart. So cephalic veins. This just inflow here, feeding artery, arterial anastomosis, all this area. This is the feeding artery, and the outflow this is a veins already which AV axis drains into the heart. Okay, as we mentioned before. Physical exam of AV fistula, just for thrill, you should palpate for thrill, and here for bruit or murmur, and check pulsatility already by palpation too, and we'll see now. Inspection, just look for AV axis length and diameter. You should look for this, and I will see next slide. Inspection, just will see length of your dialysis axis, AV fistula. You should look or inspect for aneurysm, any aneurysmal dilatation, any warning sign of rupture, any infection or scar or rash in your fistula or around the skin of surrounding your fistula. Arm swelling, you should compare both arm of your patient. Any cyanotic hand or gangrene, you should look for that. Fistula maturation, just put this in your mind, and to remind you, fistula maturation, AV axis length, diameter, flow for suitable cannulation. Fistula maturation means your fistula is suitable for cannulation or no. This is according to length of your fistula and the diameter of your fistula and thickness and the flow through your fistula. Rule of 6, fistula assessment, just don't forget rule of 6. 6 week post-surgery, don't say not creation, because we are not creating anything as a human being, just creation from Allah subhanahu wa ta'ala, not from a human being. Just only we are just said 6 week post-surgery, not post-creation. 6 week, number 1 in the rule of 6 in fistula assessment, 6 week post-surgery at least. And maybe maybe 8 weeks, maybe 12 weeks, according to the maturation of your fistula. At least diameter 6 millimeter, diameter depth 6 millimeter, and the blood flow 600 ml per minute, 600 ml per minute. At least the length of your body of your fistula, this outflow, this is a vein here. Wait, again, I will show you. Length of this body of the fistula at least 6 centimeters. This is the length of your body of your fistula. This is the body of your axis. You should be a 6 centimeter. Okay. يبقى now 6 week rule of 6 week post surgery. Number 1, 6 week post surgery is time, diameter, السمك بتاعنا السمك بتاع الفيستولا، العرض بتاعها لازم يكون 6 ملم عشان الكانيوليشن والبرفوريشن والرابشر for easy cannulation. الدبس ما تكونش تحت عميقه، تحت الممرضه تدور بالنيدل تحت وتغرز النيدل وتعمل رابشر وتعمل برفوريشن. لازم تكون 6 ملم، يعني نص سنتي تحت الجلد. الدبس بتاعها ما يكونش اكتر من 6 ملم. لما تشيك البلاد فلو by double ultrasound should be 600 ml per minute, and the length of body of a fistula 6 centimeter. 6 week post surgery, 6 millimeter in diameter, 6 millimeter in depth, 6 centimeter in length, 600 ml per minute blood flow. I hope that's clear. Time 6 week, diameter 6 millimeter, depth 6 millimeter, length 6 centimeter not millimeters. لا اللينس لازم يكون طويل عشان تقعد تدي مساحة للتو نيدل to give distance to T needle between each other to avoid the recirculation. Okay, at least 6 centimeter, and the blood flow by Doppler should be 600 ml per minute. And this normal radiocephalic fistula, already here, this is the body of your fistula. And this radiocephalic fistula again here, and this again, this is the body of your fistula, should be 6 centimeter. And this brachiocephalic fistula here, this is the body of your fistula too. And this transport for arm cephalic veins, and just the cephalic vein already come here, and it transports to basalic veins, and this loop of natural AV fistula, just doing loop for the fistula, and this just forearm basalic veins is transported to create radiocephalic AV fistula. احنا خدنا البازاليك فين ورحنا على وصلناه بالراديال وعملنا، وده البادي كله بتاع مين؟ بتاع الفيستولا بتاعتنا. And the forearm basalic veins is transports to create a loop of configuration and anastomosis. Okay, that's already this taking just a basalic vein and connected to a radiocephalic radial artery, and this is the body of your fistula. This basalic vein to the radiobasalic vein to radial artery. This is the basalic vein, just taken here and transposed here. Is longest car already. For arm loops, arteriovenous graft, here we have graft here. We have graft already, synthetic graft already, is to cephalic veins. And this we'll discuss later what is the issue for that. And here also the upper arm arteriovenous graft, like here in basalic veins. Just in basalic vein already to cephalic, and this graft already just easy to palpate. This already you will see under the skin here, and here also you will see, and this is already hard material, already synthetic material under the skin. And this is sleeve up for AV graft. What means by sleeve up for AV graft? You know, this patient with synthetic graft, just check frequently for this cephalic veins, because this maybe will mature with the time, will be mature, and the diameter will increase with the time to because the graft, short lifespan is not so long, is there is high risk of thrombosis, and maybe will need to be or infection, whatever is high risk than a native AV fistula. With the time after AV graft, just continue monitoring this cephalic veins, and this will be matures with the time. You can use as a secondary native AV fistula again. Just with this already, we know the type of fistula now by looking or inspection. Second step, look for sign inflammation or infection, like redness or infection here, redness and pain. Because this buttonhole, it means the same site of needling each time. This already because you already damaging nerve here, and the patient can't feel any pain during needling. But already better to use a step ladder. Just I can put a needle here and here, and next day and every day you should change the site of the needle. This is a step ladder better than a buttonhole. This is the issue. Just this is alarming. Also, you should ask your doctor to prescribe antibiotic and check the patient if he needs vascular drain or no. Maybe this fistula need vascular draining. I have one patient I saw, I think 1 month back in hemodialysis, with the same fistula start to be redness and inflamed like that. Same this picture. Just I prescribed for him already augmentin, and they revert to vascular. Second day he went to lower for drainage. And other issues is allergic inflammation, maybe from plaster, from local disinfection already by betadine or whatever using in your units, or chlorhexidine. That's a skin allergy or rash. For this, we can change the type of disinfection. Look for aneurysm and hematoma. This we have common. This is a mistake by nursing doing this hematoma, or maybe sometimes the needle moved from the site of needling, dislodged needles, and lead to this subcutaneous extravasation of the blood here. What you'll do for this patient, don't forget rice. Rice means rest for this fistula, and elevate the arm with ice. Ice just only one day, don't get, and not too cold, because we saw one patient already complicated by skin peeling from, she's using ice still in next hemodialysis, and we found the fistula already skin peeled already in next dialysis. Please just maybe ice, maybe 6 or 8 hours or 12 hours after the first discovery for this hematoma, and this just give rest. And you can give a fistula. If the patient still on CVC line, you can dialyze from CVC line and keep the fistula rest for 1 week. And no compression. Don't do compression. We are doing compression another issue, not just patient. Just put rice to remind you, just to give rest, ice, and elevate the arm at home. And didn't let your patient, don't allow for him to sleep in his arm, and let him to elevate in a pillow beside him at night. And just ice or cold water at least for 12 hours after that, and after that you can use hot water. Okay, just we are using ice just to do vasoconstriction to avoid more extravasation and more bleeding. And don't use ice too much, because this will do peeling and may will be more infection for your fistula. And this aneurysm, this is stable, no alarming sign, no issues. If it's chronic already aneurysm and the patient is stable, no issue. And I will show you the alarming aneurysm now. Just so you should know what means by a stable and unstable aneurysm. Unstable aneurysm is shiny, thin skin, ulceration, crusty, prolonged leaking, rapid enlargement. And we'll see here, look for this fistula. Look for this bending rupture. Maybe you will rupture at any time. Any simple trauma can lead to rupture of this fistula, or hypopigmentation top here with nodding. This is high risk for rupture too. This is shiny skin. When you are doing ground, we saw this fistula is a risky fistula. You should repair, urgent for vascular repair for this fistula. Otherwise, your patient is bleeding from here and he can't control his bleed, maybe sleeping at home, or maybe in the street, maybe anywhere, and no one can control the bleeding, and patient will end by death. Take care. You should early repair for vascular to decide to correct this fistula at any time. At least do your part, but this need urgent. For this fistula, I will refer back to a vascular surgeon to deal with this fistula. Arm elevation test, when the extremity is elevated. And this is a test just taking second, maybe with any patient to come to the unit, just ask him to elevate his arm, and we'll see now. When the extremity is elevated, the fistula will collapse completely if there is no outflow obstruction in outflow veins in the body of the fistula, the blood to go into the heart. When the extremity is elevated, the portion of the fistula distal to the point of stenosis remains distended while the proximal portion collapses in normal fashion. Here in this picture already we have this fistula. Just I ask this patient like that. I ask him to elevate his arm like that. He elevated just a second, he will be collapsed like that. If not collapsing means we have outflow stenosis with the direction of the blood to the heart after dialysis or after the fistula. Otherwise, if you will ask the patient to return back this arm, this collapsed arm, he will return back again like that. This is an easy test. It will take only seconds, this arm elevation test, just to check for outflow stenosis for your fistula. Arm elevation, raise the arm above the level of the heart. If a fistula will collapse if there is no outflow of vein stenosis, but it won't collapse if there is outflow stenosis. If you have outflow stenosis, it will not collapse. This doesn't work for AV graft due to high level of pressure in AV graft. This already will not already work with an AV graft, okay? Because you have high venous pressure. Just I found this also in other videos. Just this is a normal. This arm already with already dilated fistula, neurismal dilatation. Just ask the patient to elevate the arm and then we return to collapse like that. If it's not collapse, it means we have outflow stenosis here. This is outflow. This is the body of the venous outflow, the body of the fistula for needling. If you have this dilatation and already we have stenosis post fistula here, that means the outflow stenosis for your fistula if no collapse. Arm swelling, when you are looking for your patient, just check his arm. I told you, compare the arm of the patient. If this indicates central vein stenosis. We have one patient already after AV fistula creation, he start to be his left fistula, left arm swelling and facial swelling and the neck swelling. The typical picture of central vein stenosis, especially subclavian stenosis. And if you look for his chest or her chest, you will find collateral veins. You will find dilated tortuous veins on his chest. And the cardiac device point toward the central vein stenosis, okay? And if you are doing echo and just a central vein radiograph or CT angiograph, or you will see all this central vein stenosis. As you'll see here, there's a collateral here in the arm of the fistula. You will see collaterals and the collateral also here. And this also, and the arm swelling, sure, in comparison by the other side, we have an arm here swelling. We'll compare him with this. The right arm already swelling. This is a typical picture of central vein stenosis. And this arm already edematous and the swelling because poor blood outflows return to the heart with stenosis. Large collaterals here, severe central vein stenosis. Is too bad. You should go to angiography and stenting dilatation of his central veins. And this is the same picture of the patient. We have already one patient like that, already was chronic patient, and his left arm already like that. And this we have the problem if the patient don't have other access, oral access problem. We have stenosis, the right side and femoral, and everything is complicated. Just only this, just we need only just intervention to solve the problem like that. Is little bit is swelling here in comparison by this, and this swelling in comparison by this. With all picture of central vein stenosis and arm swelling, you should compare your, just ask your patient to examine his arms and hemodynamics. Don't forget this. It's a simple issue, and you will discover, maybe you'll discover early, and if early intervention better than late, because otherwise late will be complicated surgery. When you are doing your round, we are in hemodialysis, look for ischemia. Just ask the patient to open his arm like that. Please show me your hand, and you will see is any change in color, in ulceration, any gangrenes, anything. You should examine this both hands and both upper limb of your patient during your dialysis round to rule out Steele syndrome. Look for ischemia and cyanosis, pain and pale, cyanosis, whatever the type. Just palpate your fistula or feel your fistula. And we need to know inflow assessment, augmentation test, outflow assessment, hyperpulsatile, absent thrill, and feel for accessory veins. And we know all this. And how to palpate, the best side to palpate by your palm of your hand. Here's this side or this side. This is the best side to palpate, or most sensitive part to palpate the thrill of your fistula. and the tools for palpating LV fistula. Yeah, this is the best site. Palm tools, this area and this area is, you can palpate thrill by this tool, and this only tips of the finger for pulsation only. You will palpate thrill, just put your palm of the hand in the AV fistula or the body of the AV fistula, you will feel thrill. This is indicative, is normally will feel soft, continuous during the diastole, systole, this continuous thrill already. You will feel during systole and diastole. In presence of stenosis, the thrill become short and disappear during the diastole. You will feel, maybe you will see. Yeah, like this, and with music sound, just not continuous. Like on the other side, we'll see. This is a continuous soft thrill and soft, not like that high pitched and just only systolic thrill without flow stenosis. Just normally, the fistula, as we mentioned, is not pulsatile and is very soft and compressible. No pulse and just only soft continuous thrill and compressible when you are doing pressure on the fistula. With the occlusion of the outflow, it is very pulsatile. After this stenosis or occlusion, the fistula will be hyperpulsatile with absent thrill if you are do occlusion to outflow of your fistula. The strength of pulse is directly proportional to the arterial flow on the feeding artery, radial artery. This is a feeding artery for your fistula, and augmentation of the fistula we'll see now. Juxtaanastomotic venous stenosis is the most common site for venous stenosis. This is the stenotic site, easily diagnosed by palpation of the anastomosis and distal veins. Normally, a very prominent thrill is present at the anastomosis site. When you auscultate the fistula, the prominent site or the highest thrill you will feel or palpate as the anastomosis side of the fistula is soft and easily compressible, with juxtaanastomosis stenosis or water hammer like mitral valve incompetence, or this water hammer pulse and aortic incompetence is felt as anastomosis. The pulse goes away rather abruptly at the site of the stenosis is encountered. Above this level, the pulse is very weak and the vein is poorly developed. Above this level, because already we have stenosis. Palpation and auscultation are used to identify stenosis and vascular access. Palpation and auscultation. Stenosis can be outflow or inflow, involve the outflow phase, or this inflow stenosis involve the artery or the arterial anastomosis or the juxtaanastomosis. Here, physical example of a normal fistula, soft and compressible. When you are palpate for thrill, just you will feel thrill means the flow. You will feel soft and compressible thrill, okay, by palpation. And thrill and bruit have high intensity, low distance side of the anastomosis. In this area, if you put your stethoscope here, you will find the highest sound here at the site of anastomosis. And when you will go here, the sound will decrease gradually, okay? As we mentioned, normal thrill is a soft, continuous systolic thrill, soft, continuous systole and diastole during systole and dystole, with a soft, continuous systolic thrill. If you have with this stenosis, if you have stenosis in this area, this will be increased localized to the area of the lesion of systolic only. Just will increase this thrill will increase just the pulsation of systolic thrill during especially at site of the anastomosis. As we mentioned, soft compressible, this is a normal one, and this hyperpulsatile here. If you have stenosis here, you just will put your hand here, and you will feel this hyperpulsatile and decreased thrill also. Hyperpulsatile indicate downstream resistance. This venous outflow. This is the body of the fistula. This is a venous outflow, and this is a feeding artery. This is a radial artery, and this capillaries veins, for example. And these veins will take the blood to the heart. We have stenosis here, and this will lead to hyperpulsatility of your dilated fistula with absent thrill at this area. This is a normal flow through a normal fistula, capillaries vein, and radial veins. Flow is equal each where here. This continuous pulsation and continuous thrill, same all over the long of the track. Okay, this is a normal serial, soft continuous serial, soft continuous serial, same. If you have stenosis, localized serial systolic only at this area. If you will feel by your stethoscope or palpation, you will feel just localized serial or perwee serial systolic only, or perwee high pitch systolic only by auscultation. This is by palpation. This is outflow stenosis. Okay, and distended here pulsatile with absent serial, except if we have accessory fades. Outflow of venous stenosis, forcibly pulsatile and firm distal to the stenosis, enlarges rapidly, often taken on aneurysmal or near aneurysmal proportion. Absence of serial distal to the outflow stenosis, we'll see now. Absence serial in this area. Serial will be absent here, just pulsatile fistula in this area, and this high pitch serial or perwee by auscultation here. Absent serial with outflow stenosis. Absent serial with outflow stenosis. I will not repeat back. مش هنحاول نكرر تاني الحاجات عشان ما نلخبطش الناس. I will not let you be confused. Just if you like to listen again, just to go back. We'll go straight, because if any disturbance here, you will be confused. Okay, I need you to concentrate now. If we have now outflow stenosis in the cephalic vein and distal to fistula, this absent serial will be absent serial here, just with high pulse here, just pulsatile fistula with absent serial. You are okay now? We have clear now outflow stenosis for our fistula. With the body of the fistula, the blood going to the heart. Okay, pulsatile. He will give you pulsatile here. You will see this pulse like that, and you will new palpate, serial disappeared. Okay, clear now. This clear outflow stenosis. Assess the pulse over the AV axis. Pulse augmentation is used to assess inflow portion of the AV fistula. We'll see now. Pulse augmentation to assess inflow. Pulse augmentation for inflow to AV fistula. If you will compressional body, if your fistula is outflow, this is a feeding artery, red one, feeding artery, radial artery, and this will feed your fistula by blood from the heart, and this body of the fistula outflow part, this is cephalic veins, this will take the blood from fistula to the heart. If you do compression A here and compression B, the inflow is good when occlusion at point here. If you do pressure occlude this point, you will do pressure here and occlude this point. This should be pulse augmented in this area, and the serial should be disappear. No serial here, and the pulse will be augmented. Just this is a simple test, the pulse augmentation technique. Just put one finger here and one finger on the site of anastomosis, and when you occlude this area or press on this side of the body of the fistula, you should feel the pulse will be augmented in this area, and the serial disappears. This is a normal fistula. And again, if you will do pressure here, as we mentioned, this A, and you will palpate here, you will find this pulsatile pulse here increased, and the serial will disappear. This is normally pulse augmentation with absent serial in this area, just hyperpulsatile here without serial with normally. Okay, and inflow augmentation with poor inflow. If you will do pressure here in the body of the fistula and no hyperpulsatility here, no increase in the pulse in this area, and no serial, no pulse augmentation in this area inside of anastomosis when you are pressing the distal to the fistula, and no pulse augmentation, no serial, no pulse augmentation, no serial in this area, means inflow stenosis. We have here stenosis in this artery, radial artery, and I show you here inflow stenosis here. This hypopulsatile fistula, this suggests inflow stenosis. If you are doing pressure to distal to the fistula, and you will pay at the site of near the site of the anastomosis, no pulse here, no hypopulsatile, and no serial. This means we have inflow stenosis if no pulse augmentation here. I hope is that clear. Inflow again, inflow augmentation. If I do augmentation test here, and no pulse augmentation, and with normal serial. If we have serial here, means we have accessory veins. This is the cephalic veins and this radial veins, and you are doing pressure to distal to fistula, and you palpate here for pulse augmentation, no pulse augmentation, and no serial now. This means normal serial now, normal serial, accessory vein. If no serial and no pulse augmentation means inflow stenosis. If no pulse augmentation, but serial is still here, still you palpate serial, that means you have accessory veins, So you will go to next step now after augmentation test. This is a sequential occlusion test to detect the level of accessory veins. Sequential, okay? Occlusion test to detect the level of accessory veins. I will do 2 hands here, 1 hand to press and 1 to palpate, and we'll just move up and down until you detect this, the actual site for this accessory veins. If you will palpate here, the occlusion at this point, serial disappears, so it's okay. This point will occlude because the accessory is still here. If you will press here and you will palpate here, serial will be disappear. If you will occlude here and you will palpate here, serial is still persistent. It's clear. This is a sequential occlusion test. When we will use this sequential occlusion test, if I have hypopulsatile in this area, I will press here and I feel here hypopulsatile, no pulse augmentation, and with normal serial. If I occlude here and still normal serial here, the serial should be disappear. But if serial is still persistence, means you have accessory veins. When you press here, just will do sequential, just to move this hand to press here and here and here to detect this accessory vein. What is his side? This sequential. What means by sequential? When I press here and I will palpate here, I will find the serial still here, and it means the accessory vein in this area. At this area, okay. As we mentioned, this accessory veins. Just if you will press here and palpate here, you will not palpate serial. If you will press here and palpate here, you will palpate serial because this large accessory veins, these accessory veins already taken blood from this and will lead to poor maturation of AV fistula, needs surgical occlusion or coil embolization, whatever surgery will do. And then the direction of the blood from the leading artery to the fistula to outflow arterial body of the fistula, cephalic veins, and some blood escape here, and this will not allow to your fistula to mature. You need to be occluded. Again, if you will press here, no serial now. If you will press here, still serial running, serial here. Just to more a clarification. And if you will press here and the accessory is here, serial is still working, and the fistula, maybe this accessory artery in this area need to be occluded or coil embolization as a vascular prepare for that. I hope that's clear. I hope that's clear. You can repeat again and again until to be clear with you, and don't forget that. Because I read that many times in books and no benefit. Okay, that's I'm trying to clarify by simple way to finish this headache. For what you need to do as a palpation for your fistula. No more than this. Don't confuse by other tests. Just at least know that and fix in your mind, and that's enough to check your fistula and hemodialysis. Okay, listen. You should listen for bruit or murmur. Bruit or murmur. I don't say listen for thrill. Thrill, this palpation. Bruit or murmur, this is auscultation. Okay. Bruit is a sound of murmur heard over the fistula. Normally, soft, continuous murmur. Soft, continuous murmur. Okay. Abnormally systolic, abnormal murmur or systolic murmur only. This is abnormal one, systolic. Normally you will find this continue. This is normal soft. But high pitches, low systolic, as I said for you, it means outflow stenosis. Fistula try to push blood. This again is this stenosis, stenotic area, like an aortic stenosis or mitral stenosis. Low pitched, quiet systolic murmur, this is inflow stenosis. Now, if you found low pitched, quiet systolic, low pitched means this is inflow stenosis. Just when you are hearing, just hear the whole arm and the heart, please. Hear along the entire length of your arm, all the body of the fistula, the blood going to the heart. You'll that's to hear any abnormal murmur. To differential diagnosis, this murmur came from fistula or from heart. just try to occlude the body of your fistula or cephalic veins, the blood out the fistula. Just try to occlude that and listen for a murmur on the heart. If the murmur disappears, this means a murmur came from the fistula. If you occlude the fistula and the murmur still persists, this means organ is the heart. You should check for infective endocarditis and check for echocardiogram. If your patient is septic, you can do that. And you should do routine examination for your patient. I hope that clear also. If you to differentiate between the murmur from the heart or from the fistula, just occlude this outflow cephalic veins by your fingers and listen for the murmur. If this appeared, this means your murmur came from the fistula. If the murmur doesn't appear by pressure, means your origin is the heart. You should do echocardiogram to rule out infective endocarditis, especially if your patient is septic. I hope that point is clear and simple. happiness السعادة كلها ان انت is a lifelong well functioning AV fistula. AV fistula equal your patient life, your hemodialysis patient life. Now we'll continue our round now. I give you just a hint before starting around during our hemodialysis unit. I give you basic of AV fistula or access examination during a round. Now Dr. X, Dr. Y, Dr. Z will start our round now. What is access problem we'll see now? We can see primary failure, bleeding, thrombosis, steel, aneurysm. Start your round. Start with me now. Okay. Access problem, fistula, primary failure. You want to get called about this. Yeah, why? Because already surgery done, and after surgery, no thrill, finish. Already fistula died from the first day. Or poor fistula, no thrill at all. Already this, you want to get called for about that because already finished by nurse or a nurse practitioner or a vascular coordination already. What you'll do, nothing will do for that. Continue dialysis through tunnel line. And revert to vascular to check other possibility for higher access. Maybe this is radiocephalic, he can do brachiocephalic or brachiobasalic, and we'll see. Bleeding, you may get called about this. Bleeding, I am sure if you are working in hemodialysis or nephrology before, I'm sure you are called for this bleeding before. Thrombosis, I am sure you will get called about this. You will be called. If you're not called for thrombosis, you should be called for thrombosis. Sometimes the patient came from home and already no thrill, no perwi, no nothing, just pulsatile fistula with thrombosis after fistulogram and finish. This need urgent thrombolectomy within 48 hours. Within thrombolectomy can be done within 48 hours, okay? Just now, what you will do if the patient came by thrombosis to your unit, just check lights, potassium is okay, bicarb is okay, vital is stable, not volume overload, no emergency for that. Otherwise, if you need emergency dialysis, just insert temporal line, dialyze your patient. Or if you have IR facility or vascular facility to insert an line of same settings is the best for you and for your patient. Do that, okay? Steel syndrome, you may get called about it. Steel is a common complaint during your hemodialysis round. When you are doing round, you just look for your patient hand, you will feel maybe pale or cyanosed, and the patient complain of severe pain during the dialysis. And we'll classify all that by cases now, and we'll see. Aneurysm, you should check your aneurysm for any patients for sign of impending rupture, any change in the color, any bleeding, any infection. Just we'll see all this now by picture and the cases. To enjoy with me, start now. Thrombosis, we see the first one. Absence rel, absent perwi, no flow on Doppler imaging. Management, urgent thrombolysis, thrombolectomy or thrombolysis, okay? Thrombosis, the first patient we saw on nurse call you on triage. Dr. X, I have this patient and the fistula, no thrill. I auscultate, I try to auscultate, no perwi. This means no flow. Also, you ask for Doppler ultrasound imaging for this fistula, no flow. What you'll do, just emergency referral to vascular for thrombolysis or thrombolectomy within 40 couple of days, 48 hours. AV fistula, graft thrombosis, AV fistula or graft thrombosis. priorities need hemodialysis or no. Just put in your mind this patient needs hemodialysis or no. For potassium 7 you should put temporal line, dialyze him first, then send it to vascular. Clinical status electrolyte, okay, vitally, not volume overload like that, and blood pressure is okay, and everything is okay, no need for emergency dialysis, revert to vascular for thrombolysis. Otherwise, temporal line and dialyze your patient if he don't have line. Get a sense of their electrolyte pattern or any chronic volume issue. Take a look for access history. Just look for this before to decide to put line. Don't go aggressive and ما تكونش الانسيسيزم واخداك او الحماسه واخداك قوي وتروح تحط له لاين وتخرب الدنيا. روح الاول شيك على العيان، خد الهيستوري بتاع العيان ده، عنده ستينوزس هنا، ستينوزس هنا ولا لا. شوف الهيستوري بتاع الفاسكولار اكس بتاع المريض ده الاول، وشوف بالدبل الترا ساوند هتقدر تركب ولا لا. لو عندك الترا ساوند حاول، ولو ما عندكش الترا ساوند في الوحده بتاعتك لازم تجيب الترا ساوند. لم من مرضى، والله انا لو في اي مكان، لو رجعت اي مكان ده، لو ما معيش القدره نجيب الترا ساوند لازم تجيب الترا ساوند في الوحده عندك. لو كل مريض يتبرع باللي يقدر عليه، ولازم يكون عندك دوبلر الترا ساوند في الهيمودياليسيس. والله يا جماعه ده احنا كنا دايما في مصر طبعا كله بلايند ده كارثه ومصيبه اصلا. ساعات الواحد لما الواحد بيستخدم بقى في الدول الثانيه اللي اشتغلنا فيها عموما، وهنا كمان قبل ما تستخدم تبص الاول على الفينز، لان انت ممكن تلاقي الفين اصلا كلودد، ممكن تلاقي فين سمول والارتري تحته كده. طب وممكن تلاقي اليمه الثانيه افضل، وممكن تبص على الفيمور وتشوف الدنيا وتشوف في اي مشاكل ولا لا في الفينز. لو باين ثرومبوز هتشوفه مقفول، لان لو بتركب فيه ممكن تلاقيه ستينوز صغير وتحته ارتري كتير. لو انت دخلت اصلا بلايند هتعك الدنيا وهتجيب الكاروتيد وهتبهدل المريض. اتمنى الرساله توصل للجميع. حاولوا تجيبوا دلوقتي في باتر فلاي. ده الباتر فلاي ده ممكن تشغله على الموبايل بتاعك، تحطه توصله بالموبايل عندك وتشتغل عليه وتشوف يا سيدي الفوليوم اسيس بتاع العين في الدياليسيس، تشوف الامبيروفينا كيف. لو الدايمتر بتاعه اقل من 2 سم زي الفل، لو اكتر من 2 سم معناه فوليوم اوفرلود. بتظبط بيه التارجت ويت بتاعك. تتعود تشوف البي لاينز في اللنج، تتعود تشوف الفينز قبل ما تيجي تركب. مين اللي هركب فيه مين؟ ممكن تيجي رايت تلاقيه كان مركب قبل كده واستنوزد وضيق ومسدود ومتنيل. طب وليه تروح الليفت تلاقيه زي الفل؟ عشان عندك دوبل الترا ساوند. فانا بصراحه والله يعني يا جماعه احنا دفعنا كتير وصرفنا كتير يعني، وحياتنا كلها ضاعت في الموال دي. فاحنا كدكاتره وكمرضى لو حاولنا، بالذات مرضى الغسيل يا جماعه، المرضى ده يخفي اللي هم فيه بصراحه ويخفي المعاناه اللي هم فيها. واكيد هتلاقي حد من مرضى الغسيل ناس مبسوطه وناس تقدر تعمل وتخلي. انت حاول لو انت في مكان عشان تشتغل صح، تشتغل نظافه، نظف المكان بتاعك. طالما انت موجود في المكان وبتاكل منه عيش وخلاص وحياتك اتظبطت على المكان ده، حاول تخليه بيرفكت، وحاول تتعلم تعمل سيستم وبروتوكولات. وحاول، انا هديك يا عم بروتوكولات، اعمل كل حاول تظبط انت البروتوكولات ديت عندك. هديك والله بروتوكولات لكل شيء. هعمل لك، هحاول اقدم لك كل البروتوكولات اللي تقدر تظبطها عندك. انا قلت لك قبل كده في السي ار ار تي ممكن تعمل بروتوكول عندك، في السليد لو سمحت محاضره السليد هتعمل بروتوكول عندك. هديك بروتوكولات لكل الالكترولايت ازاي تتعامل معاها، هديك بروتوكولات لاي شيء انت تتوقعه هعمل لك. انت حاول تسمع وتعمل انت بروتوكول لنفسك ظبطه، لان انت لما تكتب الحاجه بنفسك انت المستفيد. الحاجه دي لان انت مش هينفع ان انا نبعت لك بروتوكول، وما نقدرش اصلا نبعت لك بروتوكول بتاع مستشفى ثاني. فانت حاول تسمع وتلخص الكلام وتظبط انت المكان بتاعك، خليك مترستق. يعني يقول لك عين هايبركاليميا، فولو ذا بروتوكول اوف هايبركاليميا، يبقى البروتوكول جاهز. ما تقعدش افكر ادي كالسيوم وادي مش عارف ايه ودي وتنسى حاجات وتحط حاجات وتخرب حاجات. وكل حاجه لها نظام ولها بروتوكول. وهحاول ابعت لك، هحاول اعمل فيديوهات عن البروتوكولز، how I can do protocol for that, how I can do protocol. يعني هقول اظبط، حاول تظبط المكان بتاعك، مش عشان حاجه، عشان تاخد ثواب، تاخد يبقى انت كده عمل وريحت، وفي الوقت انت هترتاح والمريض بتاعك هيرتاح، وهتحس المرضى يحبوك وتحس انت انجزت في المكان بتاعك. والارزاق دي سيب على الله، سيبك من الرزق ده خالص. الرزق ده ابدا مكتوب لك، والله لو فين هتاخده. يعني الرزق ده اوعى تفكر حد ياخد منك رزق. ولما اقول لك المعلومات اللي عندي كده تتقلل انت كل ما اديك اصلا معلومات ربنا بيبعت لي معلومات اكتر مما تتصور. فيعني سيب على الله. والناس هنا اللي هم ما يعرفوش ربنا يعني عموما، الناس دي بتديك معلومات كده بدون اي مقابل، يعني بدون اي مقابل. يعني لو واحد غيره يعني يعني تحس عندنا في مصر يقعد يعمل لك في المحاضره يشنكلها ويقفلها لك وممكن ما يديهالكش اصلا، وممكن تتحلل لي عشان يديها لك. يا عم لا، الكلام ده مش موجود هنا تماما. واتمنى ان شاء الله الجميع يستفيد من المحاضرات ديت، وان شاء الله خير. وحاول تغير من نفسك ومن الوحده ومن وتعمل بروتوكولات لكل شيء. ما تخليش الدنيا ماشيه بهزر، مش كل واحد يجي فاكر كلمتين يعكهم ولا يسهم في مريض ولا يسلك المكان. انت حاول، لو انت مسؤول عن المكان، انت مدير المكان، مدير وحده الغسيل، مدير وحده الكلى، حاول تعمل بروتوكول لكل شيء. حاول this manual guidelines for your units. انت بتجمع من هنا ومن هنا وهنا وتعمل بروتوكول محترم تمشي عليه، تكون وحدتك منظمه كده، كل حاجه بالسيستم. عيان مريض غسيل تكون كده بروتوكول، مثلا زي ما انا قلت لك، اول ساعتين، اول فيرست هيموداليس سيشن لازم الكرايتيريا 1 2 3 4. السكند هيموداليس سيشن 1 2 3 4. الاريثروبويتين اللي انت عشان تديه البريكس او الارانيزبا او الدرب بويتين او المرسير، الحاجات دي كلها لازم كلها بروتوكول عندك في الوحده. الاميونو سبريشن ميديكيشن للترانسبلانت لازم يكون عندك بروتوكول في العياده، ما تبقاش الدنيا ماشيه بهزر. الترانسبلانت بري اند بوست سيرجري، لو انت في مكان فيه ترانسبلانت لازم يكون عندك بروتوكول قبل العمليه وبروتوكول بعد العمليه. ايوه، في بروتوكول لما العين بيجي لك وتحضره وتجهزه وياخد الميديكيشن قبل العمليه، والميديكيشن اللي ياخدها وقت العمليه، والميديكيشن اللي ياخدها بعد العمليه، والتحاليل اللي اتعمل قبل وبعد، وهي الريفيرا اللي تتعمل لمين ومين ومين، ولو دايابيتس يكون ليه بروتوكول، ولو يخلي كل حاجه منظمه. تيجي بعد العمليه، ايه بقى الميديكيشن اللي هيستمر عليها بعد العمليه وكذا كذا تكمل. يبقى في بروتوكول ثاني بوست اوبراتيف، يبقى في بري اوبراتيف بروتوكول اند بوست اوبراتيف بروتوكول. الكونتراست، عيان هياخد كونتراست هو السي كي دي ورينال امبيرمنت، ما تنساش الكلام ده، لازم يكون في بروتوكول عندك في المستشفى. على الاقل لما تجيب استشاره من الكارديولوجي والحاجات ديت، ويكون عيان ماسك كارتين 200 ولا 300، يبقى عندك بروتوكول فولوز بروتوكول اوف كونتراست والسي كي دي او اي كي اي. حاول تظبط وتغير حياتك وتظبط السيستم وتمشي زي الناس زي العالم المتقدم دول ما هم ماشيين. حاول ما تبقاش انت وتبقى الدنيا ايزي يا جماعه، هتلاقي الدنيا ايزي وبعد كده انت اللي ارتحت. اي نعم هتتعب شويه، بس انت هينوبك ثواب ان انت عملت الموضوع ده عندك، وحطيناها صدقه جاريه ليك وعلم ينتفع به الى ما شاء الله. وانت اللي هتبقى زرعت الفكره دي في المكان اللي انت فيه. واتمنى التوفيق للجميع ان شاء الله. عشان ما نطولش عليكم، اتمنى بس يعني تستفيدوا، وان شاء الله يعني نحاول نكونوا كلنا يعني نافعين ربنا ينفع بنا العباد يعني. المهم يا سيدي، عندنا جاست في فور ايفي فيستولا اند جرافت ثرومبوزس. لما انت رحت شفت المريض بتاعك في الوحده، لقيت الفيستولا ما فيش سيريل وما فيش بروي، خلاص ثرومبوزد. انا اول حاجه اي بي سي اوعى تنسى كلمه اي بي سي دي في حياتك عموما. انا شايف العيان الاول، وبعد كده وتعمل ريفيرا وتعمل كل، ابعت لاب الاول، سند الشيست اكس راي لو عايز، شوف الفيتال ساين بتاعت المريض كله ستيبل مش محتاج ارجن دايليسيس، بيروح الفاسكولار بامان يعمل سيرومبوليز والسيرومبوليز. لو في حاجه محتاجه ارجن دايليسيس، لو ما فيش تنال لاين حطوا له بقى تنال لاين، بس بعد ما تشوف بالالترا ساوند وتشوف الاكسس هيستوري. تمام يا سيدي. في البيشنت ستيبل مي ايبل تو جو هوم اند ديبندنج اون الريسورس. لو انت ما عندكش الفاسكولار، ممكن عمليته بكره ولا بعد بكره، المهم يروح الهوم، تروح البيت عادي. لو ما فيش ارجن دايليسيس انديكيشن، يروح البيت ويجي بكره تاني وتعمل له لاب تاني وتشوف الفاسكولار لغايه ما يروح الفاسكولار. ما تنساش تسحب له سي بي سي واي ان ار بالله عليك، تعمل له اي ان ار بي تي تي. السي بي سي عشان البليتلت نشوفوها، والهيموجلوبين والوايت بلاد سيلز عشان لو في انفكشن، والهيموجلوبين والبليتلت عشان لو محتاج بلاد ولا في ريسك اوف بليدنج. والاي ان ار البي تي تي والاي ان ار لازم تعملهم ضروري، على الاقل الاي ان ار عشان لو في السيرجري تتعمل وهو فمان يعني. اوكي يا ريس. ليت الاكسس تيم طبعا بترنج مع الفاسكولار ولا الكلام ده كله. بيست ويندو فور اي فيستول از ويزن كابل دايز، زي ما قلت لك انت بتحاول تعمل ثرومبوليز او ثرومبولوكتومي ويزن 48 hours. اي في جرافت كان توليريت لونجر. تمام. No anticoagulation required acutely. Sometimes the vascular may recommend while waiting surgical revision for a repeated thrombosis issue. Don't forget that. Maybe the vascular recommend heparin and stop before surgery, no problem. Case, we'll start by this case now in hemodialysis, 67 years, male patient in the serial disease, in intermittent hemodialysis, on left brachiocefalic AV fistula with large concerning AV fistula. As by his nurse or charge nurse. هنذكر بالخير أختنا الغالية أم عبد الرحمن. أم عبد الرحمن كلمت مين؟ أخونا الغالي الدكتورة شحاتة، بلاش الاسم الأولاني، دكتور شحاتة. دكتور شحاتة، أنا عندي مريض عمك مقبولي ولا مدبولي عشان ما نذكروش اسماء حد. المريض ده 70 سنه، ميل بيشنت على دياليسيس، ليفت بريكوفاليك فيستلا. انا مش مرتاحه للفيستلا بتاعته، الفيستلا كده اللارجد وانا مش مرتاح عليه. شحات هيروح لها على الباب ويمسك لها دجنه كده ويشد فيها ومش هي تقول لي الله المستعان. والله كانت ايام. المهم الممرضه قالت لك يا سيدي، او الهيد نيرس بتاعتك قالت لك، طبعا الهيد نيرس دايما في الدول اللي بره بتحترم، وعندنا حاجه اسمها نيرس براكتيشنر، دي بتشيل معاك الحالات، بتشيل معاك الشغل زيها زي الدكتور بالظبط. فانت لو في نيرس عندك هيد نيرس او نيرس على الاقل عندها دايما تعرف النيرس في الهيمودايليسيس اشطر مننا بكتير، لان هم دايما في احتكاك مع المرضى قبل انت ما تبدا شغل كده، وخاصه الكرونيك نيرس. لو عندك نيرس شغاله بقى 10 12 سنه، طبعا دي حافظه كل اللي بيحصل في الهيمودايليسيس. فحاول يعني ايه تخليهم زي اخواتك، يعني انت المستفيد يعني، وكلنا بنفيد بعض باذن الله. المهم يا سيدي، فام عبد الرحمن جابت لك العيان ده وقالت لك الفيستله دي انا مش مرتاحه لها، وانا حاسه كده ان الفيستله ديت فيها شيء غريب، عماله تكبر كده، والحجم بتاعها انا خايف تربشر ولا تنفجر والعيان يموت ونبقى احنا السبب ونبقى قصرنا مع العيان. فشحاته يقول لها انت عايزه مني يا ام عبد الرحمن بس يا ام عبد الرحمن. فالمهم what do you think now لما ام عبد الرحمن تقول لك الفيستله دي large concerning every fistula what do you think. فالمهم يا سيدي، انت لازم تحترم اي، لما تجي لك الممرضه ايا كان تيجي لك باي مشكله في حاجه كده وهي مقلقه منها، لازم تحترم الكومبلين دي وتروح تشوف وتركز، لان انت ممكن تكون انت مريت وما بصيتش اصلا. يا عم مريت وما خدتش بالك، انت ايه انت غرمان يا عم، مش هتغرم دقيقتين ثلاثه، لان ده ممكن تنتهي بكومبليكيشن وتقول يا ريتني كنت رحت شفت. وممكن عموما يعني ممكن مره تعمل دوكيومنتيشن وبلغتك وخلاص وانت المسؤول، يعني ممكن يحصل كومبليكيشن وتكون انت اتبلغت ويجي بقى راجعوا الدنيا دي كلها. ودايما لما بيراجعوا بيروحوا يدوروا على النوتس بتاع التمريض، اخر حاجه بيبص على النوتس بتاع الدكتور. تمام. What do you think now؟ ايه اللي انت شاكه دلوقتي يا عم شحاته بقى يحط في دماغه ايه بقى وجع القلب اللي جالنا ده يا جماعه؟ بقول لك ايه، انا اروح اشوف العيان احسن بدل ما نلبسه ايه بتاع ماشي. فالمهم بعد اللارج كونسيرنج فيستلا what do you think is going on، بدل ما نلبسه مصيبه ولا حاجه. المهم what is the feature is least concerning about this fistula، what is the least concerning. انا بقى لما تقول لي الفيستلا كده، الفيستلا نيوريزم از جيتنج بيجر، الفيستلا دي الحجم بتاعها كبير يعني ولا ايه، ولا ممكن ترابشر. هل الفيستولا دي على السكين بتاعها ممكن يكون سيك وتشايني وهي لاحظته وانا ما لاحظتهوش؟ ام عبد الرحمن شافت السكين كده شايني كده وشكله هينفجر ولا حاجه وانا ما خدتش بالي، ولا كان عندها هي بصت في النوتس اللي انت ممكن ما بصيتش عليها، عندها العين ده عنده 3 جلستين اللي فاتوا عنده برولونج بوست هيموداليس بليدنج برولونج، هي شافت ده وشافت الفيستولا بالمنظر ده، فقالت اما ننبه الدكتور. ولا مالتيبل انيوريزمال اريا نوتد، دي شكلها ممكن تكون مشاوي يعني عادي يعني. ريسنت انجيوبلاستي فور ستينوزس، لو العند عمل ريسنت انجيوبلاستي ولسه الفيستول عماله تكبر، او في بليدنج بعد الدياليسيس، او السكين برضه الستيل تشاين. المهم يعني الحاجات الكاركتيريه بتاعت الريسك فور رابشر دي ايه هي؟ بقول لك الليست concerning about this fistula will see in the end of this case aneurysmal fistula with impending rupture. ده اللي هي مين؟ ام عبد الرحمن خايفه منه. قالت لك الفيستولا دي دايليتد فيستولا with impending rupture، انا خايفه ترابشر. انا على الاقل ببلغتك وانت تروح تبلغ الفاسكولار بطريقتكم بقى مع بعض. AV axis aneurysm can be caused، الانوريزم ده بيحصل من ايه؟ increase access flow، increase inter access pressure stenosis or repeated cannulation at same site. بيحصل repeated cannulation at same site with increase inter access pressure and increase access flow، كل ده بيعمل weakness في الوول والتن الفيسرة بتاعتك تكبر تكبر تكبر. تمام. hence it's very important to rotate the cannulation site. This better don't use this button hole, just better to stapler technique is better. surgical intervention for aneurysms depend on، انت تحول بقى للسيرجري، السيرجري هيتعامل مع العيان لو هل هو نورمال سكين؟ لا اوبزيرف. هايبوبيجمنتد سكين، وات مينز باي هايبوبيجمنتد؟ السكين بتاعك بني، يجي عند الفيستولا هتلاقيه مبيض هايبوبيجمنتد، البيجمنتيشن قلت. just observe for elective versus elective repair. لو انت شكلناها هنوريك دلوقتي الصور. شاين سكين، ام عبد الرحمن شافت لك شاين سكين قالت لك ده محتاج سيرجري، ولا اسكر شافت لك اسكر على السكين، قشر كده على السكين والان شكل السكين كان فيه انفكشن وبعدين عملت قشر عليه، وممكن القشره دي لو اتشالت هيجي البتين مطرطر دم على طول. او السر، لو لقيت السر على الفيستولا سيرجيكال ريبير immediately. لو لقيت السر، لقيت الاسترال عليها السر كده وده محتاج ممكن الالسر ده يربشر في اي لحظه، او رابيدلي لارج انوريزم. شافته يا عم المره اللي فاتت والنهارده لقيت المره اللي فاتت كان جد البليه ودلوقتي بقى زي الكوره. لا ده لازم يروح للفاسكولار او يتنوم. المهم دي الكرايتيريا عندك، اوعى تنسى. نيرس يا نيرس يا هيموداليسيس نيرس بليز لوك فور ذيس. If anyone shiny, scar, ulcer, larger aneurysm, please call your doctor to refer the patient to a vascular surgeon for impending rupture AV fistula. High risk patient, save life of your patient, please. كيس برزنتيشن، بالله عليك انت لو شفت فيستلا زي دي هتروح البيت والله تبقى مجرم. This is a seen and denuded. ده توديه للفاسكولار، ما يروح يقول له ما تروحش البيت، والله هتروحش البيت، تلفها له محترم كده وتقول له شوف من الفاسكولار بتاعك يا حاج افتكر عليه. المهم او تحوله عندك لو انت في مكان محترم يعني. seen denuded، دي في الفيستلا عامله ازاي؟ shirty, shiny and not benchable. دي بيجمنتد، شوف البيجمنتيشن هو اصلا الجلد بتاعه اسود وهنا دي بيضه خالص، دي بيجمنتيشن. السريشن طبعا واضح كمان في السريشن هنا اهو وفي اوزن كمان منها. سبونتينيوس بليدنج كمان شغال مع نفسه مع الالسريشن اللي هنا دي. هنا مالتيبل السريشن this يا الله hypopigmented seen it shiny. This is a typical case or typical fistula need now to go from no dialysis. Don't do any cannulation here. Don't touch this fistula. Please send your patient to a vascular area as urgent, and maybe the vascular also will put tunnel line. No need to wait for tunnel line for this patient. This is a life-threatening now. This is a technique, just don't forget this. هتجيب غطا ازازة مية. This is already. This is to stabilize your patient. تجيب الغطا أي إزازة عندك تحط الغطا وتحطها على الفستة دي وتلفها له جامد، وهي دي لوحدها هتعمل ثرومبوز وكلوتنج هنا وهتقفل لك الفستة. تمام. Effective method developed and implemented by Kidney Care UK, United Kingdom. Already this is effective method already for in rupture fistula. هتجيب غطا أي إزازة مية عندك، أي غطا إن شاء الله بتاع المحاليل اللي عندك بتاع البايكار بتحطه للعيان. Take a plain bottle cap and apply direct pressure over the bleed. Over the bleed هتحط هنا. Tamponade the bleed until the patient to be taken to lower. تمام. فكرة جميلة جدا. واتمنى تكون وصلت للناس كلها. اي رابشر فيستل عندك شوف اي غطا بتاع زي ديت ويحطه على مكان البليدنج وتلفها له لفه محترمه ان شاء الله برباط ضاغط لغايه ما يروح العمليات. تمام. To save your patient. تمام. With the life save. I hope everyone just attended for that or take attention please for this point for in rupture fistula in your unit. Hypopigmented skin. I told you hypopigmented. You look for this area. Here start to be hypopigmented, is brown, dark brown, and here is whitish. Observe for elective repair, just refer to surgery. If you see this hypopigmentation, better to be referred to a vascular to correct this fistula. Shiny, refer to surgery. If I saw this fistula and this hypopigmented here and shiny here, hypopigmented here, shiny here, refer to surgery for repair, please. And this multiple all sizes and shapes of different aneurysm. I think that picture is better to refer to surgery. This risk also, and this start to be shiny with a little bit intermittent hypopigmentation, and this hypopigmented also, and it also hypopigmentation. Better to refer to surgery to be in safe side and protect your patient to correct all this aneurysm. Fistula rupture, clinical manifestation and mechanism: weakness in the wall. The wall of your AV fistula is weak now. Aneurysm are dilatation of the entire wall of the fistula. AV fistula only. Pseudoaneurysm are hematoma. Pseudoaneurysm means hematoma that communicate with the axis via defect in the wall of AV fistula or AV graft. Now, aneurysm, dilatation of the entire wall of the fistula. What is the difference between aneurysm and pseudoaneurysm? Aneurysm, dilatation all entire walls of a fistula. Pseudoaneurysm are hematoma that communicate with the axis via defect in the wall of the AV fistula or graft. Surrounding tissue forms a seal over an enclosed hole on graft due to over cannulation at same site area because of buttonhole technique. CT scan, brown aneurysm, prolonged bleeding, necrotic scan, overlying infection, ulceration, associated outflow stenosis. CT scan, groin aneurysm, prolonged bleeding, necrotic scan, overlying infections, ulceration, associated outflow stenosis. Risk factor: repeated cannulation, same signs as buttonhole technique, repeated or recent angioplasties, high blood flow, high pressure from stenosis. This is the risk factor for fistula rupture. Take care. This skin ulceration over the fistula. skin ulceration, and already this ulcer already referred to surgery, and is doing this stage. Differential diagnosis, benign aneurysm, management and prevention, rope leader technique or cannulation technique. rope leader زي السلم كده ما تحطش في مكان واحد. avoid cannulation in aneurysmal area if possible, or groin fistula. avoid cannulation. Identify groin aneurysm, prolonged bleeding, high pressure. Identify groin aneurysm from and prolonged bleeding and high pressure, high venous pressure, and consult the vascular surgeon. In groin aneurysm, any prolonged bleeding post dialysis in high pressure, just consult the vascular surgeon. And this already different shapes of shiny aneurysm with this oozing or bleeding here, with the skin ulceration, bleed, refer this fistula to a vascular surgeon. Question: who's worse, this or this? What do you think? What do you think? Who's the worst? Which is the worst now? This right one or left one? Right? Did the right or right for you here? This or this? Whatever. I think it's the worst one because you know here this is shiny and a little bit hypopigmented more than this. And this looks like ulceration here. It's better too. This is the most risky fistula, need to be referred to a vascular surgeon. This is a surgical emergency. Don't you الله والممرضة راحت كده. شوف دي غشيمة دي غشيمة. دخلت في الفستلة هنا دي انت ما تلمسهاش اصلا يا ماما دي تروح للفاسكولار على طول. هنا برضه هنا الفستلة هنا اهي. شوف المنظر عندك ulceration وكراستيشن ulceration cluster. والله دي تروح للسيرجن افضل طبعا. and which worse انا عايز نشوف دي worse ولا دي worse. هما الاثنين المفروض يروح للسيرجن بصراحه لان اي واحده فيهم لو العيان تشال القشره ديت او اتشالت باللزقه ولا حاجه ممكن ما تضمنش اللي هيحصل تحتها. بس مين الورث في دول؟ دي طبعا شايف الاسكر الموجوده هنا دي، شايف القشره المدببه دي لو اتحكت في حاجه والمريض حب شالها بيهرش ولا حاجه وشالها رابشر دايركت. لكن دي فلات كراس دي is the more safe and this is the most dangerous. AV fistula can lead to AV fistula, natural AV fistula, aneurysm or pseudoaneurysm. AV graft only form pseudoaneurysm. يبقى natural AV fistula can do aneurysm and pseudoaneurysm. AV graft only pseudoaneurysm. And they lack a true vascular wall. ما عنديش أنا true vascular wall. Pseudoaneurysm is essentially hematoma communicate with AV fistula access lumen. Just مجرد hematoma حصلت ودخلت في الفاسكولار lumen. تمام؟ Pseudoaneurysm, this is a picture of pseudoaneurysm, not typical aneurysm, just a hematoma. Manifestation of rapidly expanding pseudoaneurysm, size increase, doubling in size, skinny changes, deep pigmentation, shiny, thinning and tooth and shiny. This shiny picture and thin skin and depigmentation, this rapidly expanding pseudoaneurysm. Vascularization, ulceration, eschar formation, spontaneous bleeding, hemorrhage, or bleeding from cannulation site, prelude to rupture. This is area, and this is the time before rupture. Arm elevation sign will not collapse. With arm elevation, not collapse. This is a pseudo aneurysm. Skin integrity issue, hypopigmented skin eschars. This is hypopigmented here with eschars. Think here the skin not healing well and high risk for rupture too. Scab, قشرة اللي ناشفة ومدببة ديت is a medical emergency. Please refer to a vascular surgeon. يعني ده لو المريض حكها أو اتشالت أو لزقة أو أي شيء كل ده هيروح. What feature is least concerning about this fistula? Fistula aneurysm getting bigger. This already is need to refer to surgery. Seen shiny need to refer to surgery. Bleeding, prolonged bleeding post hemodialysis needs vascular. Multiple aneurysmal area is noted. We have many patients with multiple aneurysmal and stable, nothing emergency here. Recent angioplasty for stenosis, this need to be referred to. This is a concerning about the fistula, multiple aneurysmal. This is the least concerning, other or concerning for urgent referral. Case 2, we finish now aneurysmal and we'll see Mr. X now. In the dialysis patient, we saw infection in his AV axis. It can be superficial infection and whatever in general, superficial or deep. Avoid cannulation at near the infection. ما يكونش العيان عنده infection ولا في باص ولا في inflammation وتروح تحط لي الكانولا. يا تقدر تحطها بعيد يا ما تحطش خالص. العين ياخد ريست وتشوف الاول ياخد انتبيوتيك وتظبط العين، او ممكن يحتاج فاسكولار درينج او debridement and we'll see. Superficial infection can be treated with maybe sometimes simple infection can be treated by just augmentin or cefazolin or whatever. Yeah, antibiotic, but deep infection requires surgical intervention. Okay. Deep infection at the cannulation site we have here. This is a picture of infection. Please don't cannulate. Give antibiotic, revert to vascular surgery for drainage. Access infection, CVC, more than AV graft, more than AV fistula. AV fistula is the least one. The least infection will be happening with a native AV fistula, followed by graft, followed by CVC. CVC is the most common source of infection in hemodialysis. Signs, symptoms, the patient maybe will come by fever, febrile, chills, hypotension, plus or minus acute worsening from septic showering on dialysis. Fever, chills, hypotension, septic showering on dialysis. Patient will go to sepsis, septic shock. Pain plus or minus noticeably fluctuant abscess near the axis. ممكن تلاقي pain plus or minus abscess near the axis. With an emergency, admit page access team. Just admit the patient to call the access team, do blood culture, empiric antibiotic coverage, imaging, Doppler, histogram, whatever of the axis, and just to call or refer the patient to vascular surgery. Graft may require urgent removal. If you have graft, maybe need urgent removal. Superficial infection at the cannulation site, like this, you can give antibiotic and you can, if the patient no urgent dialysis, just keep him rest and give antibiotic local and systemic, and we'll see next hemodialysis, and if not improve, the revert to vascular. This fistula already should be referred to vascular team. This already was pus oozing from the fistula. That means this patient antibiotic septic workup and vascular urgency with Doppler and the histogram. Which is worse now? I need you to think with me. Think. Who is worse? The one with the white one or this brown one? This fistula or this fistula? This already swelling here, red area, needling site, okay, swelling one. Is this red and tender area, very tender area, and febrile with chills, febrile with chills. Febrile with chills means this patient will go to septic shock. Take care, this is the worst one. This is the worst one. They became septic quickly and admit access salvage, maybe with drainage, with debridement by vascular team urgent as possible. This patient with fever and chills and abscess here. Any patient with fever came to emerge and AV fistula, please examine his AV fistula. If there's no abscess or inflammation, because maybe you need urgent vascular repair and salvage of your fistula. Cough migration. This other issue when you'll see the nurse will call you Dr. X. The cough of this patient is out now. I saw the cough at the exit side. Don't push the cough inside. Don't push the cough inside. What you will do is chest X-ray. If the tip is still inside the heart, start your dialysis. Stabilize your axis by good dressing. And ask the patient to watch his catheter and the cough and exit side till we'll arrange for vascular exchange. Don't push the cough inside. If you will do pushing or a vascular can do pushing at this stage, please give your patient vancomycin cefazolin as a prophylaxis and take all blood culture for your patient and follow your patient for infection after that. Take care from that point. Partial migration calls access team. This is a vascular team in your unit, okay to dialyze. If it's chest X-ray is okay, place a very secure dressing. Inform the patient to watch that. If chest X-ray is okay, patient can be dialyzed, but don't forget to schedule him for exchange for his catheter. What's wrong here is the same cough already at the exit site of the fistula. And also look for here, there's a racema on the tunnel because the cough here is out and already infected exit site. This is a racema means tunnel infection now. Racema above the tunnel. If you will do examination for your patient, like a BD patient, you can do milking here. Just press this from inside here to outside. Press milk. Do milking pressure here, and we'll see any pus here. You can take for culture urgent. If it's infection, staph, pseudomonas like that, you should remove this line. Okay. Here, just a source of colonization. Colonization in dialysis patient in a multiple source, either from this line for saline or from any line here, or from nurse, and or from the skin of the patient, from dressing, from any part here from your catheter. Central venous catheter dysfunction, your nurse will call you Dr. X. The catheter no flow. No flow means you just do TBA lock. You should have the protocol I said for you. You should have protocol for you, for your nurse, to TBA catheter. Just thrombolysis to any clot inside. Do thrombolysis to your catheter. Just TBA lock. At least for 1 hour. What is named this gas flow? Just to do gas flow or TBA lock for your catheter at least for 1 hour. And we'll see this is thrombolysis for any clot inside your catheter. And we can discuss this in future. What is the dose and what is the protocol? I will mention for you in other presentation. This is as regard catheter dysfunction. This is the first time or second time or third time. If frequent, you should be change this catheter. Exit site infection, please. If your patient is stable, CBC, CRB, and no leukocytosis, no febrile, vitally stable, you can give antibiotic, take swab culture, and the blood culture, and we'll see next time. Line-related bloodstream infection is a common problem in hemodialysis. Patient came by fever with chills or history at home. Fever, chill before he came to dialysis, just COVID screen, blood central peripheral culture, exit site culture, and urine culture if available. Take all bank culture and the COVID screen for any patient with fever in hemodialysis. Line-related bloodstream, 2 sets of culture to make the diagnosis. Rule out other source of infection like COVID, chest infection, UTI, GIT. Just treat with your patient as CREPSI, catheter-related bloodstream infection or line-related infection until proof otherwise. Start empirical therapy, set dependent based on local. This is according to your local protocol. Just please cover gram-negative and gram-positive. Some centers use cefazoline and ceftazidime. Cefazoline 4 gram-positive and ceftazidime 4 gram-negative, 2 gram, 2 gram. Other center can use vancomycin, tobramycin, gentamicin, whatever, according to vancomycin 50 milligram per kg or 1 gram per 1 gram once, and we'll check the level next time. And gentamicin same, we can give 40 or 80 or 2 milligram per kg, either tobramycin or vancomycin, and we can repeat the next hemodialysis according to the blood level for tobra or gentamicin or vancomycin, if you have facility to do level next time. If you don't have, just start simple cefazoline and ceftazidime to 2 gram post each hemodialysis until the result of culture, central and peripheral and exit site. Okay. Cefazoline, tobramycin, ceftazidime, if significant residual urine function, avoid the aminoglycoside and keep ceftazidime priority with cefazoline 4 gram negative, 4 gram positive and 6 gram negative. Consideration for admission if your patient is hemodynamically unstable and febrile and blood pressure is low and he is going to complete his dialysis, please better admit him and arrange for line removal, line replacement as we mentioned. At least we just for standard definition of CREPSI, catheter-related bloodstream infection. At least 1 positive blood culture obtained from the peripheral veins, clinical manifestation of infection, fever, chills, and hypotension. Same organism must be isolated from the catheter segment. We have central and peripheral blood culture, same organism, with signs of infection, fever, chills, and hypotension. This is the definition of CREPSI. We have different definition. Don't know why this slide not appears here. As we mentioned, just I will see the problem in this slide. Just I mentioned empirical antibiotic to be used for any patient with suspected CREPSI. This will start gram positive, gram negative according to your local protocol, according to your center. You can use cefazoline and ceftazidime, or use cefazoline and other aminoglycoside, either gentamicin or tobramycin according to available, and we'll check level in next hemodialysis. This is the empirical antibiotic I discussed before. And then the protocol, you should take this protocol, that protocol and put in your units for any CREPSI. I think this is a common protocol. You can take picture now. I will just try to remove this for you. You can take a picture for this protocol and you can put in your unit for any gram positive and gram negative, and you can read. And the most common is gram positive cocci already for our dialysis, but the most dangerous one is Staph aureus and Pseudomonas already, and this is for indication for removal if refractory to treatment. And I think for gram positive at least 2 Staph aureus 3 weeks antibiotics coverage, and the gram positive negative coagulase staph just we can use for 2 weeks, and Pseudomonas or gram negative maybe we'll use for 3 weeks too. And then Pseudomonas, just my message for you, any Pseudomonas or gram negative bacilli, especially Pseudomonas, should use 2 antibiotic. We can use ceftazidime or tobramycin or gentamicin as IV medication during the post-H dialysis, with ciprofloxacin oral to cover. He needs his organism already, by my experience, he needs 2 antibiotics according to guidelines, not only 1 antibiotic enough for Pseudomonas. And we'll repeat the culture maybe after 1 week, and we'll see if the patient is responding or no. If refractory, we can remove the caster at that time. Staph aureus, if the patient already, or this patient will have access problem. And if the patient already with Staph aureus and refractory tool management, he should indicate for removal of this line. And any patient with refractory and staph, just please don't forget to do echocardiogram to rule out vegetation and the heart from this catheter. Don't forget that. Any patient with back pain, don't forget to do MRI for spine to remove metastasis of cystic embolic infection to the spine, metastasis for the septic emboli for that. Don't forget this message for you. Any CRIPSI, they mentioned for you, any hemodialysis came from home by history of fever, COVID swab first, central peripheral blood culture, chest X-ray to rule out chest infection, and take the whole history of the patient to give you provisional diagnosis where you are. Maybe just came by back pain or chest pain. This means infective endocarditis, maybe with bone metastasis and infection. Just to rule out all of this, please don't forget any point. Take central peripheral blood culture, COVID swab, virology, whatever, and urine culture, blood culture, chest X-ray, and the stool analysis available. If the patient with gastroenteritis, start your empirical antibiotic take after you are taking all this culture. If the patient is stable, send after dialysis to send him home is okay. If he is unstable, admit him. Otherwise, don't forget echocardiogram to rule out any vegetation, and don't forget MRI for spine if your patient complaining back pain. When should I not return the blood to a patient? Suspected type A dialyzer reaction. Suspected type A dialyzer reaction, don't return the blood to the patient. Suspected hemolysis, as we mentioned before, suspected air embolism, suspected blood leak, and contamination of the circuit if your patient febrile or shells like that, and you think the circuit contaminated, please don't return the blood to your patient. For hemodialysis line insertion, just review the complication. Most common complication, when you should discuss all this complication with the family or the patient if the patient is competent. Please just don't forget to discuss the risk of any complication before insertion, and let him to sign consent, please, to avoid problem for you after that if you will not mention the patient or the family for that. Either arterial puncture, this is a common if you are using blind, and this is rare now by ultrasound. Hematoma after that, and pneumothorax is a common complication after line insertion. Temporary, should ask told the patient this maybe will be having, and let him to sign for that. If you will do that, you will protect yourself and your patient and your family from any problem after that. And the patient if accepted and the family is accepted, everything will be okay. Most common just infection DVT, especially with the femoral line, please. And the other complication mentioned here, cardiac arrhythmia and the cardiac arrest. We have already one patient arrested because they were given too much lidocaine. I think this lidocaine is given after arterial puncture to the blood streams and to the heart, and after that doing cardiac arrhythmia. And the patient already sudden arrest during insertion. And I saw another patient with pneumothorax already shifted to ICU, chest tube inserted and drained, that after that survived. Take care, don't forget this is the most common arterial puncture, hematoma, pneumothorax, the most common infection, DVT with the femoral line commonly. Arrhythmia, air embolism is a common also, the common complication can be happened during the insertion. Just regard the side for right internal jugular, just use 15, 14, 13, 16, whatever available for you. According to you, maybe adult 18 years, 15 years, and he's small, just use 13 or 14 or 15 maximum. Maybe adult, you don't find any catheter, just don't use long catheter, please. Just use, because we have one patient inserted the catheter here, 19 or 20 centimeter on the right side, and already attached it to right ventricular arrhythmia, and the patient died in the brain anoxia with our colleagues. Don't put a catheter length more than 16 in this side. 16 is maximum, 16, 15, 14, 13 is okay. 13 better than 20, 13 better than 19, okay? Let him to dialysis, and after that you can change, because sometimes we can't find any dialysis size available in our center. Just pediatric side, I can use pediatric side better than I put 19, and the patient will go to arrhythmia, because the tip of the catheter will go to the right ventricle and will stimulate the arrhythmia for the patient, and the patient will be ended by arrest. Here in the left side, we can use 16 or 19. 19 is better. If you are afraid from the length of the catheter, your patient small and short, neck and short, you can use 16 is safe. Femoral 19, 20 is okay. Femoral 19 or 20 according to the size. And sometimes if not available, you can use 16 or 15 too, no problem. But better the length in the femoral. And it's the side of tunnel catheter. On the right side, 24, 28. Here, 28, 32 on the left side. Here around 40s, here around 40s also, the right and left femoral. Another case, 42 years old female on hemodialysis with right hand pain and discoloration, swelling. She has right AV fistula. Another patient, 42 years old female on hemodialysis, has right hand pain and have discoloration, swelling. She had an right AV fistula. وانت بتمر على الغسيل، بنمر على الغسيل كده لقينا واحده ست ثانيه عندها رايت هاند بين، والايديها كده لقينا بيل اور بيل تو bluish and swelling. She has right AV fistula. Pain 10/10. She can tolerate crying all the time during the hemodialysis, even after giving her analgesic. Right upper axis continue per week, continuous cereal, minimal pulsatility, moderate augmentation, hand warm, slightly swelling, dusky skin. Like, what's your next action? When you saw this patient in hemodialysis, complaining now, when you saw Mr. F in hemodialysis, right hand pain, hand discoloration, swelling, and complete severe pain, crying from pain. And now, what's your action, boss? What you will do now, please? What you'll do now? Fistogram, Doppler, MRI, echo, plethysmography. Plethysmography is used to check the blood flow and the clots in the arteries. What you will use now? Just please, fistogram, first choice for this patient. Any patient with Still syndrome, fistogram first. And then the indication of fistogram, swelling of the whole fistula arm, prolonged bleeding, more than 10 minutes post-dialysis. On more than one occasion, despite optimization of the coagulation region, increased size of the aneurysm, persistence problem with clots more than 3 millimeters in diameter, unable to achieve dialysis blood flow for at least 300 ml per minute, 25% fall from baseline, and either achieve the blood flow on dialysis or fistula flow transonic measurement within first 1.5 hour of dialysis. Recirculation more than 5%. I think recirculation accepted if less than 5 or 10% or up to 15%. If recirculation more than 5% on 2 consecutive dialysis sessions, you should do fistogram. If the only indication of fistogram, you should know if dynamic venous blood pressure more than 150. Unexplained fall in URR, maybe stenosis with recirculation, with the indication of fistogram, you should put in your mind, okay? Fistogram already in our patient, we already did fistogram, show severe stenosis on the right brachiocephalic fistula. What you will do next? You did now fistogram, severe brachiocephalic stenosis. What you will do next? The patient already reverted vascular angioplasty done and placed the stent in the right brachiocephalic fistula. Angioplasty with the stent already done for this patient. The case conclusion that the central vein stenosis causing venous congestion, mechanic arterial steal physiology in this case. Have you seen a case of severe central vein stenosis presenting with feature of Steele syndrome, and did the angioplasty of the central venous stenosis lead to symptoms resolution after this angioplasty? This is all related to central vein stenosis, picture of Steele syndrome. Okay, this is a case, and you can make this case at any place. This is a fistogram. This shows stenosis here in this area and this area. and this already access flow already done. And this is our patient when examine her hand, already in the right hand. Just to show you this peripheral, just bluish discoloration, dusky, and this skin ulceration, and start to be peripheral vascular disease and maybe impending ulceration, and will end up by gangrene. Here is this area, and this histogram already done for this patient. This is already pre-angioplasty and post-angioplasty. This is pre with the occlusion in this area, and now this opened already after angiogram, and this is post-angioplasty. And this patient right hand already after angioplasty, pain is resolved, and next day no surgery, discharged on the second day, pain resolved, no surgery done for just angioplasty. And just to show you this AV axis related steel syndrome will appear this ulceration. This is a benefit to examine your hand if any patient have fistula. And I think with this knee atrophies in his knees and his pale hands and the cold already, this is a sign of steel syndrome here. Just a picture to show you the picture of steel syndrome. Conclusion, venous congestion from central venous stenosis can present like ischemia in patient with a dialysis access. Venous congestion can mimic arterial steel physiology on polysysmography. This may be only seen in patients with additional peripheral vascular disease. Central vein pathology can be underestimated. Please just don't forget that. Cyanotic hand and gangrene seen in dialysis access-related steel syndrome. Cyanotic hand and gangrene seen in dialysis access-related steel syndrome. Dialysis access-related steel syndrome pathogenesis. Indication for surgical intervention or dialysis access steel syndrome depend on the severity of symptom and risk of tissue loss. Dry gangrene due to hand ischemia is an indication for surgery for steel syndrome. For this patient, this is a picture of dry gangrene due to hand ischemia. And the pathogenesis of steel dialysis access steel syndrome, we have here this outflow here. This is cephalic veins, and this our fistula, and this radial artery. You know, here the radial artery, blood stealed here. Blood steered here to the hand, and then we'll go back to feed, and this blood stealed here also to feed the fistula, and the blood stealing from the hand here to the fistula again. And this is the mechanism caused by the drop of distal perfusion pressure due to preferential flow of diversion of the arterial blood flow stealing into the AV fistula. Here we have the arterial flow stealed to the AV fistula from the blood supply into the hand. Retrograde flow through the distal. Here already retrograde steal also blood return from the hand. All this will the pathogenesis of dialysis access steel syndrome. Stages of dialysis access steel syndrome, we have stage 1 till stage 4B. Whose will be conservative and who will be surgical management. Stage 1, just will see pale hand, cool hand, no pain or cyanosis of the knee beds, and numbness and paresthesia, arterial pulse as the rest over reduced. This conservative management. If it's stage 2A, tolerable pain on exercise and or during the hemodialysis, conservative management. Intolerable pain on exercise and or during hemodialysis, please surgical intervention. If the patient can tolerate the pain during each dialysis, please refer to a surgeon. If wrist pain or loss of motor function, surgical intervention. Limited tissue loss, potential for preservation of the hand function, surgical intervention. Irreversible tissue loss, significant hand function loss, ulceration, necrosis, gangrene, please surgical intervention. You know what time you will refer and your time what you give you analgesic and wait for your patient. Okay, just often just a pale, cool hand, but no pain, no cyanosis, patient tolerated, just mild numbness. Yes, you can deal with the pain. All patient tolerated with analgesic is okay. Otherwise, let the patient to do intervention for your problem. Now, case number 2, we see this patient already 40 years, female, diagnosed with biopsy probable lupus nephritis, 7 years, and the serial disease past 5 years. 14 months after receiving cadaveric renal transplant, patient presented with right shoulder pain, tender AV fistula aneurysm. Right shoulder pain and the tender AV fistula aneurysm. Right shoulder pain, tender AV fistula, and aneurysm. The aneurysm was noted to be stable and didn't collapse with hand elevation. minimally invasive complete ligation with minimal contrast without flow angioplasty was performed under fluoroscopy with suture. Okay, did the fistula already ligated? 5 days after successful fistula ligation at the inflow, the patient presented with worsening redness, swelling, pain, fistula. لو العين عمل ligation للفistula وجالك بعدها worsening redness, swelling, pain on the fistula side, there was no pre-on palpation, and the fistula occlusion was confirmed by Doppler study. The patient was managed with rest, ice, compression, elevation of the hand. Rest, ice, compression, elevation of the hand. 10 days later, the swelling and the redness improved, and the patient was also able to move her shoulder freely. Conclusion, current guideline make no recommendation on the management of a fistula in post-transplant patient with conflicting report on risk and benefit associated with AV fistula ligation. Cardiovascular benefit from this decrease the left ventricular mass in the diastolic and systolic function volume will be decreased, the cardiac output will be improved, the cardiac index and proper NB level has been shown post AV fistula ligation. All this will be decreased. Benefit will get benefit for all this after AV fistula ligation. Okay, as regard the decrease of ventricular mass in the diastolic systolic function or volume and the cardiac output, cardiac index will get benefit for all this after post AV fistula ligation. It's important to manage the outflow tract stenosis before ligation. Any outflow tract stenosis or thrombosis better to be managed before occlusion the fistula. And this is summary for our patient is 40 years female after successful transplant. She came by aneurysm and collapse not happen for elevation of her after arm elevation for her fistula not collapsing. And after already decide to ligate this fistula and the fistula ligated after ligation, she came by pain, redness, little bit of swelling, and just treated by rest, ice, arm elevation, tight compression. 10 days or 1 week after that, just a compression recommended for 2 weeks. After that, the patient already is improving without anything. With the case, another case, a 70 years male patient in this disease, left brachiocephalic fistula with abnormal shape, long-standing thrombosed fistula as by his nurse. عبد الرحمن ماسكه شحاته، تعالى يا شحاته. في عندي مريض abnormal shape, long-standing thrombosed fistula. الله، شحاته برضه ماسك دجنه. وبعدين في مع عبد الرحمن. المهم مش عارف الحاجه دي مقتصدانه ليه. الله المستعان. المهم عندك abnormal shape, long standing thrombosed fistula. Take care from this fistula. You should examine this every hemodialysis or any patient complain for any change in shape like that. عبد الرحمن عملت تفتش في العيان فمسكت لك الحته دي، قالت لك انا الفيستula كده مش عجباني وهي ثرومبوز من زمان وبس في تغيير شكلها مش عاجبني، عامله زي الورمه كده فيها مشكله. What do you think is going on? What do you think was going on? شحاته بقى يقعد يفكر مالها الست دي، مالها كده زي تلبسنا فيه مش عارف. المهم يبقى now 75 years male patient in the serial disease IHD left brachiocephalic fistula with abnormal shape, long standing thrombosed fistula as by his nurse. What do you think is going on? لا بيتوقف ان انت عندك ممرضه بتفتش وكويسه، والله كويس انت بتكتشف حاجه في المريض قبل ما تحصل كارثه ثانيه، فكويس ان في حد بيدور ورانا يعني بصراحه، بس مش في كل الاحوال. What is to look out for؟ انت شفت الفيستula دي شكلها غريب، يا ثرومبوز العين ما بيستخدمهاش وحجمها كده، هو العين بيقول لك عماله تكبر شويه وفيها شويه بين وتلاقيها ريد وسويلنج وبينفول ويعني يوجوال ابييرنس ونوت امبروفينج، مش مريحه كده، هي الفيستula شكلها مش مريح وخلاص. long standing disuse او not used thrombosed fistula with following criteria: the red, swelling, painful, unusual appearance. هل ده بين؟ هل ده abscess؟ هل ده infection؟ هل ده مصيبه ثانيه؟ عارف بري سيرجري، شوف كانت وصلت اتعملت ازاي، شفت المنظر اتحول ازاي. ده انيشال برزنتيشن ايوه، ده بري سيرجري، شوف المنظر اتغير ازاي بقى، شكلها مخيف يا اخي. ايش هذا؟ زي طلع له كله كده ولا حاجه غريبه. ايه ده؟ ده قبل اول ما يطلق العين، اول ما شافتها مع عبد الرحمن وبعدين انت بقى حاولت الجراحه، على ما الجراح حب يشوف العيان وصلت المنظر ده. Angiosarcoma in disused fistula. Angiosarcoma. Don't forget this. Don't forget this abnormal shape, maybe malignancy here. Don't forget this shade. This is not only infection, maybe angiosarcoma. Angio from the blood vessel, sarcoma, oma. Mostly in male and disused and non-functioning fistula post-transplant precuceval. The patient may be presented by pain, mass swelling, bleeding, cough, dyspnea. And initial diagnosis, thrombosis, infection, maybe thrombosis, infection, aneurysm, abscess, skin disease, maybe in differential diagnosis. This thrombosis, maybe infection, maybe aneurysm, maybe abscess, maybe skin disease, maybe. Take a home message. Try to never ligate any fistula. Always aim to excise the body of the fistula and send for histology. Any fistula will be ligated, please, especially if chronic fistula or whatever, and with aneurysmal dilation, please take this body of the fistula take this body by vascular to histopathology. Look out for unusual symptoms and signs that don't resolve. Look out for unusual symptom and sign that does not resolve. Index of suspicion, biopsy, and repair without delay. Just raise index suspicion in your patient. If you will see your patient like that, maybe malignancy, I need biopsy from this fistula. Just maybe you remind your vascular, guide your vascular surgeon please to send for biopsy without any delay. In summary, but not final. In summary, the care of dialysis patient is complicated. I know this is a complicated unit, not easy unit. If you are starting your nephrology and you are starting hemodialysis, take care. Maybe one case will complicate the day of in your hemodialysis unit. One patient. Take care. Not easy unit to cover. Take care. If you don't take good experience, don't cover alone. Don't take responsibility alone. You need a good experience, and you should know all your patient and all problem and all your nurse and how you can deal with the files and you can check your every patient. Take your time before you carry the work alone, please. The care of patient in dialysis is complicated, especially chronic patient. Chronic patient, when you are a new nephrologist, it will do your day is miserable. Take care from chronic hemodialysis patient and from the hemodialysis unit. This is a complicated unit. Take care from this unit. There's not easy unit to cover call or whatever the cause. If you are covering this call alone and if you don't have experience, don't cover alone. One patient maybe will be miserable for you in remaining of your life. Okay, take care. To improve the care of this patient, you need to know. You know the patient first. You should know who's the patient, is complicated patient, who's the risky patient in your unit, who's the problematic patient, who's the most sick patient you should take. You know the unit and the staff. You should know everything in your unit for any emergency, and the staff who you will call, who charge nurse, who team leader for code blue or code team. You should know that and communicate effectively. You should know to communicate how with each patient. You don't know, some patient aggressive, some patient is problematic, some patient is depressed, some patient take care. Not easy to enter the unit and to communicate with this chronic patient because adapted for his doctor and the chronic doctor already. You will take time to deal with this hemodialysis unit patient. Is a chronic patient and the complicated unit, not easy unit. Don't forget those of general medicine skill. Don't forget those of general medicine skill. I told you before, if you are doing perfect or excellent with general medicine in general, you will do perfect in nephrology. Don't forget any general medicine emergency skill because you will use in hemodialysis unit. وفي نهاية هذا الفيديو نسألكم الدعاء بالتوفيق والسداد، ولا تنسونا دائما دعاء بالصحة والستر والعافية والبركة في المال والأهل والأولاد، ولا تنسوا دائما الصلاة والسلام على سيدنا وحبيبنا ومعلمنا محمد صلى الله عليه وسلم. ونترككم في رعاية الله وحفظه، ونلقاكم في فيديو قريب بإذن الله، وأتمنى تكونوا استفدتوا جميعا، ونسألكم التوفيق الدعاء بالتوفيق والسداد. ولا تنسوا بالله عليكم لو ليكم حد مبتدئ في الكلى او حد، انا كل عايز اوصل المعلومه دي لاي حد، ما حد بيقول له معلومات اصلا، بيدخلوه في الشغل وفي المناوبات من غير اي شرح، ما في حد فاضي يقعد لك اصلا وكله ملهي على اكل العيش. فبالله عليكم لو عليك حد زميلك تعرفه لسه بادئ في الكلى، حد في البطنه ومغطي شفتات كلى، فحاول تشيروا الفيديوهات دي، ان شاء الله يستفيد بيها. هو قاعد في وحده الكلى احسن ما يمسك كتاب ويقرا فيه، حاول يستفيد من الفيديوهات دي على قد ما يقدر. وان شاء الله نحاول نحط لكم الكلينيكال بوينت اونلي، ما نحاولش ندش كتير ولا نرغي كتير. واتمنى يا رب تكونوا استفدتم، واي حد ليه كومنت يعلق لي ويقول لي هو عايز ايه، اي ملاحظات يبلغنا بيها. والسلام عليكم ورحمة الله وبركاته، ونترككم في رعاية الله وحفظه، ونلقاكم في فيديو قادم بإذن الله. السلام عليكم ورحمة الله.